Hello everybody and welcome to Burn Trauma. Depending on what semester you're in, sometimes the burn trauma comes before the just general trauma, and so some of the things that we're going to talk about in this burn trauma you may not have covered yet, but not to worry. Usually burn trauma and trauma are on the same exam, so you'll get that information a little bit later of the details of the information. So if you're confused, then just hang tight for a little bit. Our story begins with a 20-year-old, 80-kilogram man who was brought to the emergency department by his friends after a gas can exploded while he was burning brush. What are your initial priorities? And hopefully you said, well, we always have to start with airway, and you'd be exactly right. Now, for the trauma assessment, there is a systematic approach, and it's known as the primary and secondary survey. And this helps nurses not only have an order to their assessment, but also to determine the treatment priorities. And just like you're going to begin with ABC. And I've posted a document in Blackboard that has that systematic approach, systematic words in there. And I think what's really nice about looking at this document is when you're looking at the airway, some of the interventions that are associated with that piece of the assessment. So again, if you're looking at airway, some of the things that you're going to do would be to suction out the oral airway, or do a jaw thrust maneuver, or insert an oropharyngeal or nasopharyngeal airway, and those kinds of things. And so it kind of gives you a hint as to what all you should be expecting to do, because most of the questions on your exams are always, well, what would the nurse do first? And I think this is a nice help. So when the trauma nurse assesses this burn victim, on the assessment, they notice that the airway is open, but there is singed, meaning partially burned nasal hair. And the individual has a raspy sounding voice. When they move on to the breathing aspect, their breaths are 24 and regular. Their respiratory rate is 24 and regular. There is a little bit of expiratory wheezing, but the O2 sat is 95% on room air. But the ED's physician calls for rapid sequence intubation, meaning the patient is just intubated right away on arrival. So why would the emergency department physician make the decision to orally intubate this patient? Why not just apply supplemental O2? Because really, when you look at the things, he's maintaining his airway and his O2 sat is just not that bad. Well, here's the deal with burns. A lot of times when these individuals initially come in, their airway is okay. But with any kind of burn, it takes maybe 20-30 minutes and pulmonary edema can set in from the burn. And this individual does have upper airway burns, and that's anytime you see that singed facial hair and the raspy voice, you know that the vocal cords have had some kind of trauma or damage to them from the burn or the smoke inhalation. And with facial hair being singed, that fire was pretty close to this guy's face, enough to where it burned his facial hair. So again, edema can occur, and these passages that are open right now, they may not be in a few minutes. And so they always go ahead and prophylactically intubate these individuals so that they're able to more easily manage the airway and ensure that there is an airway, because once that edema sets in, this patient may need a trach instead of just intubated. So it's a preventative measure. It's being proactive in ensuring that there is a very patent airway in this guy. Now, you know that in real world, there's usually, once any kind of critically ill patient comes in, there's just a ton of people that come out from everywhere. But always on your test, you're the only nurse on the planet. So in this scenario, we're going to say that the patient's airway and breathing are being managed. And then other team members are going to do the circulation part. And C for circulation includes the insertion of 2 peripheral IVs to begin infusing Ringer's lactate. Most of the time in this course, you pick normal saline as your fluid of choice, but in burns, you always pick Ringer's lactate. So again, emergency management of the patient is crucial. You can place an IV through a burn. You can put a blood pressure cuff on a burn. You don't ever want to withhold care because you're afraid of hurting the burn. It's burned. It's skin that's gone. You need to treat the patient and ensure that he's having everything done. As part of circulation, the other thing that's going to be assessed is the pulse and the blood pressure. And of course, we're looking at external bleeding. And it is really important to note too that when you take a pulse, if you're going to manually take a pulse, I mean, most of us put them on the monitor and then we just use whatever the heart rate is from that. But if you're going to manually take a pulse in any kind of trauma patient, whether it's burn trauma or just regular trauma, you need to take a pulse in a large vessel, like in the carotid or in the femoral, because you know that once compensation begins, then you can have vasoconstriction in the peripherals and the extremities, and therefore it's not a really reliable place to take a pulse. You may not feel one as well because of vasoconstriction. Back to our patient. What is the greatest risk to this patient? Well, it's a fluid volume deficit because the skin covers and protects all of our bones, ligaments, and all those structures that are in our body. But the skin also prevents the loss of body fluids by evaporation. So without that epidermal layer, then this individual is going to lose a lot of fluid. Now, in addition, just by being burned, that causes an increase in capillary permeability. And what's going to be lost is not only fluid but electrolytes and proteins. And these substances, fluid, electrolytes, and proteins, leak out of the blood vessels and into the inner space within 20 minutes of the burn. So fluid resuscitation is always very aggressive and begins immediately. And how fluid resuscitation is handled or determined is by the severity of the burn. Now, that's not a nursing function to determine the severity of the burn. And by severity, we mean depth of the burn, so the depth of the skin destruction. So that's why I put this picture of the skin. I don't remember the anatomy of the skin, which is why I'm really glad that I don't have to determine the depth or severity of the burn, but your physician's going to have to do that. And then once the depth or the severity of each area that's burned is determined, then we're going to look at the extent of the burn in relation to the body's total surface area. And we'll talk about that in detail in just a minute. So we've already gotten to ABC. Now what do we need to do as we continue our primary survey? And the primary survey's got to be completed and done fairly quickly. So in order to complete the primary survey and evaluate the burn and determine how much fluid resuscitation is needed, we need to prevent additional burns. In other words, if this individual has a lot of clothing and shoes and jewelry that are on, you know swelling is going to occur, and some of those clothes may have chemicals on them. They may be warm or still burning the skin, so they need to be removed as quickly as possible. Adherent, that's clothing that has actually been burned into the skin, is supposed to be left in place, and it'll just have to be removed with that dead skin. Now, you want to use water to cool the burn and to stop the burning process, so we use a lot of water irrigation, and that will also remove any chemical residue. And if there's any suspect that the eyes have been involved, we also want to flush the eyes with tap water. Now, we want to cool the injured area within 1 minute. So that means as soon as that individual comes in, it really does take a village to take care of this individual, because you've got to do A, B, and C, and then you've got to get all this clothing off, and you've got to cool the injured area within a minute. And of course, you know that if you can stop the burning process, then you're going to minimize the depth of the skin injury. And that's just like if you burn yourself on your stove, you know, you're supposed to stop what you're doing and go push your hand or your whatever is burnt under cool water. Large burns should be cooled no more than 10 minutes, again, because you know your skin is responsible for covering. It also maintains your temperature, and when it's gone, because it's been burned off the individual, if you cool them for a long period of time, they will develop hypothermia, and then there's a host of issues that will occur because of that. Never cool a burn with ice, because ice vasoconstricts, and you've already got a diminished amount of blood supply because those blood vessels have been burned, and you need a lot of blood supply to that burned area for healing and everything else, and so you don't want to decrease the blood flow to the injured tissue. Let's go back to what we know we need to do, and that's determine fluid resuscitation, because really the priority for this patient is fluid volume return. So to do that, as we said, we're going to determine the depth of the burn. And we think of it first, second, and third degree burns, but those are kind of the old terms. The new term is superficial thickness is very consistent with first degree burns. So you can notice that only the epidermis, the outer layer, is been affected. So the blood supply is and the pain receptors and all of that is still intact. It's pink and red. It's no blisters. A lot of pain because the pain receptors are still intact. There might be some mild swelling, so it will blanch with pressure and heals with no scarring. Now, the important thing to note, and notice that I do have it in different color, is that superficial thickness or first degree burn is not included in calculation of the total body surface area of the burn. Very important. Not included in the total calculation. And this is another reason why it's challenging to do a burn, because we can see here it's pink and red, but you do have a little bit of a scrape here. So, that's something to consider. Now let's look about second degree burns. There are two types of second degree burns: partial thickness superficial and partial thickness deep. With partial thickness superficial, this is deeper into the dermis, so it's just through another layer, and so therefore the blood supply is reduced, and this is where you usually see your blisters that are forming. So it's wet and shiny, and it's usually weeping, and again it's painful because the nerves are still intact. As opposed to the partial thickness deep, you've got maybe some blisters, but it's mostly dry. So you've got that layer has still been sheared away or burned away, but it's mostly dry. And so it might be less painful because it's deeper into the dermis, and so some of those pain sensors have been burned away. Again, it's really the physician's responsibility to determine what is first, second, what is partial thickness, superficial, or deep. I'm not really sure as far as your requirements of what you have to know in terms of what qualifies as a superficial or a deep. That would be a question for Dr. Reed. Full thickness, third degree, skin elements such as the epidermis, dermis, hair follicles, sweat glands, and local nerve endings have been destroyed. This is really burned very deep into most of those substances, and the skin reproducing cells are located in the dermis. And because the dermis has now been burnt and or has destroyed the skin generating cells, everyone with a third degree burn is going to have some kind of surgical intervention like grafting for healing. Partial thickness, so let's go back to our patient scenario now that we've identified what all the qualifications or the terms are for the different types of burn. So this patient's burn thickness evaluation by the emergency department physician reveals that there is partial thickness superficial to the forehead, cheeks, chin, neck, chest, and abdomen. So in other words, there are wet and shiny blisters, and he's complaining of a lot of pain. And then you have full thickness burn to the right arm. The skin color is red, white, and black. The texture is dry and leathery, and arm hair is absent. And then you've got a superficial thickness to the left arm. So as we've seen all of those different, or we've noted all of those different burns in the different parts of his body, now we've got to calculate, that was the depth that we determined, or the physician determined. Now we've got to calculate the burn area. In other words, what percentage, based on the total body surface area, does this individual have in a burn? So I've got a drawing here for you that identifies what parts are worth what amounts. And so what I want you to do is go back to that previous slide and determine what percent of the total body surface area is burned in this individual, because you're going to calculate your fluid replacement based on that total body surface area. And it's really a good idea for you to stop the recording and try and do it and see if your answer matches mine, because I promise you, most 99.99999% of the time you're going to have to calculate the burn areas, so you need to start learning this now. When we look at this individual's burn evaluation, we said that there was partial thickness superficial, so that's a second degree burn, to the forehead, cheeks, and chin. And when you look at that, forehead, cheeks, and chin, that's going to be 4.5% of the total body surface area. And then neck, chest, and abdomen is 18% of the total body surface area. The full thickness on the right arm means that you have 4.5 on the in the posterior portion and 4.5 on the anterior portion of the arm. Though the way this is looking, I see, to me the palm would be the back side, but in here it's looking like that the front side. I don't think that's necessary that you know that, but do know your terms because she'll slide in anterior or posterior. Now, if you were thinking, well, that was 4.5 because arm, well, when Dr. Reed lists or writes arm, that means the entire arm, front and back. So again, don't get fooled. When I did this originally, I said 4.5. I didn't list 9. I put 4.5. So it's kind of tricky on the terminology, but she has told me to tell you that when she says arm, that means front and back, anterior and posterior. Again, know those terms. Anterior just means front, posterior means back. And then because we determined that there was superficial thickness, in other words, a first-degree burn to the left arm, that is not included in the calculation. So we don't give that burn on the left side, on the left arm. We do not add it into the mix because it's not calculated in the total body surface area. So if you add 4.5 plus 18 plus 9, that comes up with 31.5%. And again, double check my math and make sure that I did this correctly. When you look at fluid resuscitation, it's based on the Parkland fluid resuscitation formula. This is another formula that you need to know. And we're going to administer Ringer's lactate at 4 mils per kg for the total body surface area of burned for the first 24 hours. So this formula is used to replace fluid that is lost in the first 24 hours. Half of that fluid is going to be given in the first 8 hours. So that should tell you immediately that these individuals do lose a lot of their fluid volume in that first 8 hours within a very short amount of time. And then we're going to infuse the quarter in a second 8 and the quarter in the third. Again, make sure you know your math because I'm going to give you the numbers for the total in that 8 hours, and then I can just guess that there'll be a math calculation that says how much you're going to give per hour. So we're going to calculate the total volume of Ringer's lactates that's needed in each 8-hour segment. And we said that the formula is 4 mils per kilogram. This guy was 80 kilograms, and we said that the burn surface area was 31.5%. So that gives us a total of 10,080 mils of fluid in 8 hours. And in the first 8 hours, we have to give half of it. So half of the 10,080 is 50/40. And then we're going to give the next quarter in the second 8 hours, and then the last quarter in the third 8 hours. So there's your total amount of fluid that needs to be given or delivered to this individual in 24 hours. So once this fluid resuscitation has been initiated, then the primary survey is now complete, and we are going to move on to the secondary survey. And of course you might have noticed that it's A, B, C, D, and then now we're going to move as the primary survey, and then now we're going to move to the rest of the alphabet, F, G, H, I, as part of the secondary survey. So we're going to do a full set of vital signs, which doesn't leave us with much. I think that's just the temperature, because we did airway and breathing right away, and then C was blood pressure and heart rate. So we're also going to, during this full set of vital signs, we're going to insert a Foley catheter, we're going to insert a nasogastric tube, and we have to assess baseline electrolyte values. And we're going to give comfort measures, history, head to toe assessment. Now, when we say give comfort measures, we talked about the fact that this individual had a 3rd-degree burn. Well, he shouldn't be hurting because he's got a 3rd-degree burn on, I think it was one of the arms. Well, you've got to remember that burns will, yes, you can have a portion, but it doesn't just burn the whole arm 3rd degree. It usually has a portion of it will be 1st and 2nd, and where the nerve endings are intact. So even if there is some 3rd-degree burn, burns, even if the whole body is third-degree burns, chances are there's a piece of it that has a first and a second in there, because it's rare that any individual will come in with just complete third-degree burns. So that's just a little caveat if you're thinking, well, you shouldn't have pain, but yes, they do. And we've got to inspect the posterior surfaces is the last thing. We've completed the secondary survey. Care is now assumed by the critical care nurse. And we're going to talk about a systematic approach to identify potential complications and their clinical manifestations, because you know this is what you're going to be tested on. Your patient has arrived with a burn. What kind of respiratory complications can occur? And what manifestations or signs and symptoms would you expect to find? Because you know, as the nurse, you're there 24/7 and you're going to be assessing that patient, and you need to pick up when there's a problem. So we're going to go with respiratory complications first. And as a result of flash burns or smoke inhalation, or really anything that causes a problem in the lungs, this is an inflammatory process, and any inflammatory process in the respiratory system or even in the whole body will put this individual at risk for ARDS, acute respiratory distress syndrome. Yes, you had it all over exam one. You are never, never, never get away from ARDS. So let's go back over the signs and symptoms of ARDS. Well, you're going to have those pulmonary infiltrates, which means that there is fluid in the alveoli. So that could be signs and symptoms of pulmonary edema, meaning we can have hemoptysis, we can have shortness of breath, we can have dyspnea. Any of those things, you listen to the lungs, you'll hear rails or crackles, and that's fluid, that's water in the alveoli. And in this instance, it is because of inflammatory process. The lungs have been assaulted from the smoke inhalation, and it is an inflammatory process that will move them into the ARDS. Notice that this can occur within 12 to 24 hours. So it happens pretty fast, and then as soon as that patient complains of shortness of breath, you listen, you hear rails, they've got hemoptysis, so you suspect, okay, that's pulmonary edema. You're going to do a chest x-ray, and then the physician's going to say, well, he's got a lot of pulmonary infiltrates, which means there's a lot of fluid where there should be air. That's what all that white stuff is. That should just be black here in the lungs, because there should only be air in there. The other sign and symptom is hypoxemia despite the delivery of high oxygen. In other words, you may put them on 40% O2. And then you notice that they're struggling, that they have some respiratory distress, the blood gas is drawn, the O2 is still low, so you increase the delivered O2 to 80%, they're still low, you increase it again, and it's still low, and that is known as refractory hypoxemia. In other words, the PO2 remains low despite the fact that you keep increasing the oxygen. Ventilator pressure alarm is going to go off, because what that is indicating is the ventilator is trying to push air into the lungs, and the lungs are becoming stiff because they're filled with fluid. The lungs become less compliant, that means less stretchy, and they become resistant to air being blown into them. So that sets off the high pressure alarm, because the ventilator has to push much harder than it did 30, 20, 5 hours ago. So it is a sign that there is something going on with the lungs. And of course, you've got to remember VAP. That's ventilator associated pneumonia. What were the VAP tools? How do the bed elevated? We want to do oral care. We want to use chlorhexidine. We do not give prophylactic antibiotics. We don't change out the ventilator circuit. I think I've got the majority of them, but go back to section 1 if you need to review VAP. Burn trauma, again, some more. Let's talk about CV complications, cardiovascular complications that can occur after a burn. And the most obvious one is going to be inadequate fluid volume replacement. In other words, if you've done the Park and Burn formula and you feel like you've given them an adequate amount of volume, but the blood pressure is still low and the pulmonary artery wedge pressure and CVP is still low, well, then you need to give them more fluid. It's not been adequate enough. Patients don't always fit in a nice cookie cutter category, and so you're going to have to use these measurements to determine whether the fluid replacement has been sufficient. Here's the other problem. This was a 20-year-old, I think. It was a young person. And so you can dump a whole lot of, you can dump 10,000 mils of fluid into this individual, and they'll probably tolerate it from a cardiovascular standpoint just fine. Now, let's make this an 80-year-old, and the patient has an underlying problem with heart failure. Well, and now the problem's going to be a little bit more difficult to manage, or fluid volume is going to be difficult to manage, because it's once you dump in a huge amount of fluid very quickly, it is easy for them to get overloaded. So again, you look at your CVP, PAWP, or PAD, and then do your assessment. Does this individual have hemoptysis? Well, again, that makes it very challenging, because is it ARDS or is it heart failure? So just you've really got to be crackerjack on your assessment. Let's talk about hyperkalemia, and I put it in the cardiac section because you know that potassium is will cause problems with with the heart rate, heart rhythm, and so hyperkalemia is often seen in right away because potassium is released from all the damaged and burned cells. If you have hyperkalemia, another sign and symptom is muscle weakness and ECG changes. I really just associate hyperkalemia with ECG changes, but you know that resting membrane potential is affected by whether it's hyper or hypo, and so we can have muscle weakness with hyper. Assess for hypokalemia, and that is a constant potassium loss from the burn wound. So initially it might be high, and then as that fluids and electrolytes are lost from that weeping burn wound, then that you might develop hypokalemia. And again, fatigue, muscle weakness, cramps, and decreased reflexes. Let's talk about circulatory complications. So this is not cardiovascular, it's circulatory complications. And we're talking about circulatory complications in the extremity. This guy had a third-degree burn on the right and then superficial on the left. So anytime you have a circumferential burn, meaning if a burn is all the way around, you're going to have very fast edema formation, and this edema can cause the occlusion of, first, usually because your veins are much more surface area, can cause an occlusion to the venous return. So once the venous return is inhibited, then what happens is the area swells more because I can't do venous return. And then because you have more swelling, now you can compress the arterial supply. And so these individuals will complain of paresthesias, pain, and then there's pressure and swelling. You could see pallor and coolness of the extremity. And pulselessness is a very late sign. When this happens, this is known as compartment syndrome. And again, I've talked about compartment syndrome in detail in the trauma, but this is really telling you again that anytime you have a lot of swelling, then you can occlude the circulatory system. And venous is usually done first, but then as it gets worse, or occluding the venous circulation or inhibiting venous return will then cause more swelling, which will then ultimately cause a problem with the nerve, blood supply delivery to the nerve, and arterial blood supply. So what are we supposed to do? Well, we're supposed to elevate the extremity, but not above the level of the heart, because we're really mostly concerned about arterial perfusion. Yes, you do want venous return, but when you have an arterial problem, arterial perfusion is compromised, then you kind of have to keep it elevated but not real high. And an escherotomy is what you see here in this picture. They have actually cut through the skin on purpose so that circulation can be returned, because when you have increased the space, now you have the ability of the blood supply to be returned. What about renal complications? Well, these individuals can go into renal failure. And again, if you haven't had the renal lecture yet, there's different kinds of acute kidney injury. That's what acute AKI stands for. This is pre-renal acute kidney injury. That means a acute renal failure from a pre-renal problem. In other words, when you don't have enough blood supply or volume that's making its way down to the kidneys cannot they will over time, like over within 40 minutes, then you can have kidney function decline or nephron function decline. So pre-renal AKI, pre-renal acute kidney injury or acute kidney failure can occur just simply from hypovolemia. And to determine whether this has occurred, you're going to always want to assess the BUN and creatinine level because that is a measurement of what's happening in the kidneys. How well is your kidney getting rid of wastes and water is really looked at or assessed by the BUN and creatinine level. Now we do want to keep the urinary output at between half and 1 mil per kilogram per hour. So for this 80 kilogram individual, we really would want to ensure that there's 40 mils of urine every hour because we want to make sure that is a definite indicator of whether the kidneys are perfused or not, and we want the kidneys to function. On the other hand, you can have great volume and you have your kidneys being perfused, but you can get what's known as intrarenal, meaning the nephron gets damaged, acute kidney failure, acute kidney injury. Here's what happens there. You've got myoglobin that is released into the circulation because you have this burned and injured muscle. And that causes myoglobin to be released into the circulation. Now, myoglobin is a fairly large molecule. And what can happen as it tries to be removed by the kidneys, because that's what the kidney does, then it can damage the nephron as it's trying to exit. And so that's one issue. You have myoglobin issue. The other thing is hemoglobin from the damaged red blood cells. So both of these, hemoglobin or myoglobin, are two substances that can physically, mechanically block and then damage the nephron. So what's the fix to this? You got to make sure that this patient is ensuring adequate hydration. It's just like a river. If there was very little water flowing through the river, then stuff that's in the river, silt, mess, whatever, it's not going to move downstream. And it's the same thing with the kidneys. If you don't have enough flow, then that myoglobin and hemoglobin can't be pushed out into the urine. So the best thing is to ensure that they have adequate hydration. We've already talked about how do you assess whether they've had adequate hydration or not. And then you want to look at the urine. What does the urine look like? If it's dark or tea colored, it's like amber, you could say it's amber, but it's like iced tea color, then you've got a sign that myoglobinuria is present, and that can also be measured in the urine. And so that would just say to the nurse, you know what, I need to reassess the hydration status if this is what I see in the Foley bag. Some other renal complications that can occur after the burn, and that is electrolyte issues. Well, you know, you can have a lot of electrolytes either staying or leaving depending on how well the kidney is functioning. You can get hyponatremia because of excessive GI suctioning, and you know, I just don't even think about this sometimes, but as you suck out all those gastric contents and gastric acids, you're going to put this individual, I didn't put this in here, but you can put them in an alkalotic state, as well as now you can cause hyponatremia because you're sucking out all of that salt. And you also can get hyponatremia just from a dilution. If you give 10,000 mils in 24 hours, that's a lot of water. And just by osmolality issues, you're going to dilute the blood because you're going to put so much water in there. Now, it might take a little while and then it'll equalize out. But at first, because of all that volume going in, you can get a hyponatremia. Signs and symptoms: hyponatremia, weak, dizzy muscle cramps, and confusion. Really, when I think about potassium, I think heart. When I think about sodium, hypo or hypernatremia, I think about head. It's really a lot about the neurostatus. So you can see these individuals can become confused. Hypernatremia because of the hypertonic IV fluids, or because of hypovolemic if you're not fluid resuscitating well enough. And the signs and symptoms, again, think brains: confusion, seizures, thirst, and a furry tongue. Hyperkalemia we've already talked about. you're going to usually think cardiac. What about GI complications? Well, you've got all of these cells that have been destroyed, and so this individual can be imbalanced nutrition, less than body requirements. These individuals need early nutritional support. I think it's been noted that really any critical care patient that doesn't get fed within 24 hours is at risk for problems and complications. And you do want to optimize wound healing, and to do that you need protein. So these individuals are going to get a high protein, high calorie, and you want to feed them very quickly, definitely within 24 hours, but slowly, because their bowel may be somewhat hypoactive, because you know that anytime you have a trauma, you've got your activation of the sympathetic nervous system, which will dampen or dump out the sympathetic, which is the rest and digest. So these individuals may not have a very active bowel sound, so you want to assess that every 8 hours. Diarrhea can occur from the tube feed or from the medications that are being administered, and then again, you know, diarrhea is a source where volume as well as electrolytes can be lost. Constipation from immobility or narcotics. So you want to assess the bowel sounds and also abdominal distension, vomiting, and you want to look at the residual in the tube feed. Curling stress ulcer is an if it occurs, it happens, signs and symptoms are abdominal pain, and then you may have some dark stools, which indicates bleeding. This is very, very stressful on a body. You've really stressed out a body, and you know that stress ulcers are always part of the mix. Infection can result as from a burn, and we want to prevent infection and reduce contamination. I think that's just the nursing mantra: clean hands, etc., etc. Cleanse and debride the necrotic or dead tissue. Necrotic and dead tissue is not going to regenerate once it's dead. Necrotic means dead. It is not going to be resuscitated, and so we do want to move those. Necrotic tissue promotes bacterial growth and delays wound healing. Once the necrotic tissue is removed, and sometimes nurses do that. Those of you at Parkland in the burn unit have probably seen this, so share your experience with others, because the majority of the students, and myself included, we really haven't had to do much treatment with a burn victim. Skin grafts will be applied. There's some terms that apply to skin grafts, whether they're from the patient's own skin or from other places, and I've got that in the notes section on this slide, what the terms are, because you know a lot of times it's not the issue that gives you on the exam that gives you a problem, it's the terminology that's used. So there's some terminology definitions. And then of course you want to report signs and symptoms of infection with changing wound characteristics, fever, and pain alterations. If there's ischemia or there's an infection to the ear, you don't want to use a pillow, because you don't want them laying on that area, because you want the cap refill to be present and to be easy. Topical antimicrobials, though we don't really think much about them in general, but topical antimicrobials are often used, because if you have skin that's been burned, especially the 3rd degree, then the blood supply is reduced, and so if you give IV antibiotics, then it may not get to that tissue that's not dead but definitely ischemic, and so a lot of times the microbials, topical antimicrobials, will be used. And then of course you always have to think about tetanus prophylaxis. What about some more integumentary musculoskeletal? These individuals can get contractures, so we need to do bedside range of motion, extend hands, arm, and elevate to prevent edema. Splints for the hands and feet. Really, I always feel like it takes a village, and you're going to need to get physical therapy in here to consult with the patient almost from the day that they get there. So you want to basically prevent and reduce deformities by ensuring that they do have really good range of motion and good therapy. And of course there's always the psychosocial. You've got scarring, you've got loss of income from this extended hospitalization, and of course just the expense. A lot of young individuals do not have insurance, and so this can be a very difficult thing to deal with. Body image, from if it's on the face, and so your chaplain can help you with that. Now, we've really talked mostly about chemical, fire, and smoke inhalations, but we do have to just mention about the electrical burn because it's in the burn trauma, so a lot of the things in general will apply to it, but there's just a couple of things that you need to consider in addition to what we've already talked about with an electrical burn. Usually, let's say a child touches an outlet, you're going to have an entrance where the electrical impulse entered, and then there's an outlet where the current escapes. And so you need to find where the exit and the entrance wound is, because if it's, say, the thumb and then it exited out the little finger, then chances are it didn't cross across the body. But a lot of times you'll see the entrance go in the hands, especially in little kids, and then it will exit out the foot, and so therefore you know that it really crossed across the whole path of the body, which means that's some extensive muscle damage. So again, myoglobinemia is got to be looked at or assessed for. The electrical current can cause dysrhythmias. You might see VFib or a cardiac arrest. And then again, myoglobin released from the injured muscle. In addition, there's all kinds of stories about individuals who climb up on ladders. My husband's an electrician, and so he always says don't get on a metal or aluminum ladder if you're doing any kind of electrical work, because it will conduct the electricity and you will electrocute yourself. You really need to be on a wooden ladder. But if you do get up on a ladder or a utility pole or anything that's up high and then you get electrocuted, well, you're going to fall. So anybody that has that kind of history, you have to be aware that they can have a cervical spine injuries because of the fall. So you're not only going to have to deal with the burn, but you're going to have to deal with the cervical spine injury. And so that's just a consideration. And when we go back, if you go back to that ABC on the primary survey, part of A, airway, was ensure cervical spine protection. So it falls way high up in the nursing assessment piece. If you have any questions, be sure and email me. This is a lot of material, and hopefully it's clear.